Here with all of you. Some of you have met me in the past. We've had the honor of working with a number of agencies around the state of all different types for a number of years. So my name is Jonathan Fite. I run Beyond Lucid Technologies, and that is pretty much as you're going to hear me say about my company tonight. If it's all right with you, I'd like to walk you through a topic that some people will love, some people will hate. Everybody's probably going to have some feeling on, which is the topic of data. Sound okay? Kind of important, everybody? Something we talk about, whether you love it or hate it? All right. I'm going to try to be a little bit interactive, and a lot of you are probably connected with me on social media. If any of you are not, feel free to. But for those who do, you might have seen me pose this question earlier today, and I didn't tell people where I was going to be presenting it. So I kind of dropped it on the world to see what happened. And it was the question of how do all of you measure health? Right? How does pre-hospital data measure health? And I think this is a question, as everybody's aware that the ET3 announcement came out this past week. EPCR is an important thing for everybody. Gets paid, there's information to flow through to others in the ecosystem, hospitals, billers, et cetera, et cetera. We talk a lot about numbers and information, and this question doesn't often get asked of what's the point of it all? So how do people in this industry measure health? It's a question I'd like you to think of. And to give you a hint, as you're thinking about this, it is a trick question. And the answer is, we don't. And so, again, to the degree that I'm not going to talk to you about any particular product tonight at all, but to the degree that this theme of understanding what it is that we do as an industry is something that is challenging everyone across the country as this industry changes. I thought it would be interesting, and hopefully it is to you all, to dive into this, but I don't really want it to be a lecture. So I thought I'd start with a show of hands, if you wouldn't mind. How many of you have heard the concept big data? How many of you have any idea what it is, care about what it is? Maybe this one, NEMSIS. National EMS Information System, HL7. Kind of this mysterious thing that hospitals use to suck in information but can't get anything back out. How many of you guys have ever asked yourself, who cares? Yes? Couple? All right. Come on, y'all can be honest. So this question is an important one on a practical level as I see it, because everybody in this room spends a whole lot of time and money investing in collecting information and submitting it into various black holes, trying to get it back out at some point. Hopefully that information gets used to make some smart decisions. And as this industry changes from fee-for-service to fee-for-value, we hear these buzzwords all the time. We talk about submitting information about patient-specific data, moving to, incident-specific data to patient-specific data. Again, this concept of sharing information with an ecosystem and changing the way you get paid, what is the point of it all? And I would submit to you, it's not what you know, it's what you can prove. And this becomes a hugely impactful part of the conversation as we go forward towards talking about this industry and its evolution, particularly as you look to share information with others in the ecosystem. Whether it's managing patients on a day-to-day basis, managing frequent users of EMS, tracking patients who are addicted to harmful substances of one kind or another, and there's somebody else who cares about that patient. Maybe it's you and your colleagues, maybe it's a hospital, maybe it's a family member, but somebody cares about that information. So the question of what the value of the data is, certainly on the one hand, to understanding how you get paid for your work. Show of hands if you've been selected for the cost accounting model under CMS. Oh, I know there are some people in the room who have. This is a very big deal. So to the degree that there is an understanding that your ability to continue your operation is based on your ability to demonstrate what you've been doing, right? EMS, fire, community paramedicine, tracking of addicted patients, substance abuse disorder patients, and so on and so forth, all based on this idea that there's information that's being collected out there that someone else has a stake in. And it turns out, as humans, we make some pretty bad assumptions. Show of hands if you've seen or heard of the book Freakonomics. Maybe listen to the podcast. How humans get things wrong. We see patterns where they aren't, and we fail to see patterns where they are. And so to the degree that the information that you collect on a daily basis, I would submit is the most important thing that this industry has going for it. There's an enormous amount of information and insight that each of you collects. But so often we forget as an industry to ask, who cares? Right? Why is the juice worth the squeeze? Is the juice worth the squeeze? Is the time and investment giving you something on the back end? And what can you gain in terms of information? As I've highlighted as a title here, the underexplored power of pre-hospital data. I hope that's something that you all take away here. There's an enormous amount of power in the information that you collect, that my company collects, that many different companies represented in this room by all of you collect, and submit into places where those data go to live and hopefully be used, be shared, be aggregated, and so on, to provide information about what comes next. So there are the extraordinary uses of pre-hospital data, some of which are emerging. How many of you heard about the shooting in Gilroy, California? Not too far away from where I live and work. There was a garlic festival, and at that garlic festival last year, there was a shooting. And there was a scramble of patients. Las Vegas shooting, everybody knows about that. A couple hundred patients had to go. Where did those patients go? Right, this concept, when I started in this business 10 years ago, a fellow who works at UCLA named Baxter Larman, so you may know the name, he was the head of pre-hospital care at UCLA, told me never to speak publicly about the concept of patients as packages. But the fact is, we're in the logistics business. We move a package that is a human, that has information about them, that has to go from one point to another, and someone needs to receive them on the other end and some information about them. Logistics, patients as packages. There's information that needs to be conveyed to somebody else. And you are the storehouses of that information. That information goes into a data system, and someone needs to be able to access it. They need to be able to rely on it. That's an important challenge. Our company was started in Pittsburgh, Pennsylvania. There is a point at the end of a bridge, represented right here, which is actually across which I used to live, that happens to be equidistant from 3 different hospitals, one of which has a vascular center, one of which has a burn center, and one of which has a trauma center. What happens if you have an accident, car accident, at the end of one of those bridges, causes a traumatic injury that was precipitated by a cardiac arrest or other major cardiac event, and then leads to a burn all over that person's body? Where do you take the person? It's an interesting challenge, and there are protocols, of course, that are put in place to do that, but it doesn't necessarily mean that those protocols are wise. It just means that those protocols were put into because someone needed to make that decision. What if you could have information collected in real time and conveyed to whatever facility you're going to take that patient to, so you know exactly why that decision was being made? And if you've got an uncooperative patient, shall we say, how many times have you wanted to take them to the place you know you need to take them, and they want to go somewhere else, and by God, that's where they're going to go, and you don't really have much information to be able to tell them what the wait time is going to be like, and whether that's the right place to take them, and so on and so forth. All that information exists in our ecosystem today. Why aren't we talking about it? So I figured we'd step back from those extraordinary uses of information and talk about the more common ones. Things like the ability to run analytics on your information, to understand your own operations, to understand statewide what's happening, to understand how your substance use challenge compares with Connecticut, compared with California. To be able to provide end-of-life information to a provider in the field when they have to know whether to resuscitate a patient or not. Because there's literally no margin of error on that one. Right? If you get it wrong, the patient's either has cracked ribs they didn't want to have, or they don't have cracked ribs and they wish they did, but they're not going to wish anything anymore. Right? These are critically important decisions that often get made in a vacuum. Wouldn't it be amazing if you had information in your fingertips? And so there's a lot of aspiration around information happening right now. And this is why I was so excited to be able to not only be here and talking to you, and again, thank you for the pleasure of being able to speak to you, but I hope this and what I'm going to try to zip through a little bit here gets you thinking about what you can do with this information. Because we talk about sharing information with hospitals. We talk about tracking patients over time, and ET3 is supposedly going to change our industry. What if I tell you that although the community paramedicine model, which is certainly grown, has roots here in South Carolina and is growing nationwide, is based on the model most commonly used is based on an error, mathematical error, because it's not possible at the same time to lower costs, reduce readmissions, and make people healthy. And the data can show you that because, as a question, who are the lowest cost patients to deal with? Anyone?
Healthy ones.
Okay, healthy ones, self-pay. How about those who aren't utilizing the healthcare system at all? They're at home, sitting on their couch, getting sicker, and worse and worse and worse, and they don't call you. And as soon as you engage in a community paramedicine program that is purported to keep them from coming back into the hospital and make them healthier at the same time, well, you have to engage with them, right? If the goal is to make them healthier, you're going to see them over and over and over, and one doesn't get COPD in general by accident. Right? So if someone has been deferring their care for 10 years and that care has been essentially building on itself, and all of a sudden these patients get into these managed care models where you're going to make them healthier and keep them out of the hospital, someone needs to engage with them over and over and over. And that gets very expensive. And so community paramedicine models tend to die on themselves. because the promises that they've made, which are not necessarily based on data, but based on an aspiration, fall apart. Wouldn't it be amazing if you could look at those patients and say, how do we make you healthier? How do we prove that you're healthier? Because I can look at the range of the variance of your blood pressure and weight gain and loss and so on and so forth over time, and I can see those numbers narrow. And I can see your medication adherence going up. And all of that information is already tracked in the data systems that the majority, if not all of you, already use today. But that information is not being used in that way, mostly because it's not being asked to be used in that way. But if I can help you change that sense, I figured, so I represent an organization that is the only technology company in this industry founded by 2 non-clinician MBAs. I am not qualified to tell you how to stick some tube down somebody's throat and bring them back to life. But I can tell you how to count the number of times you did that and how much it was worth to you. If we don't track people's health, because that's a non-question in our industry, how do we know we're making them better? How do we measure the impact that we have when we don't track that information? We track discrete data values, track those all day long in your EPCRs, right? Yes? Yes? We sort of do that with things like pain. Well, we use smiley faces and we use scales of 1 to 10. They're kind of subjective, but they're there. Medication adherence, which is really interesting when it comes to community paramedicine, but I'll leave that for another time. But when it comes to health, the ultimate end game, we don't really track that information. So EMS and community paramedicine is sort of a subset of the future of EMS run into a problem. And that problem is proving their value. EMS is having this problem across the country right now, as some of you may know. This is why you're getting the pressure from regulators at the federal level that you are. And part of that reason is because unlike, for example, a fire service, where you can calculate an impact of saving a building. You can calculate the long-term impact of saving the business that was in that building and what its contribution margin to a city's coffers are going to be over time. How do you calculate the value of a life saved? How do you calculate the value of keeping somebody from coming back to the emergency department over and over again? What if it turns out they needed to come back to the emergency department over and over again, and actually by keeping them out, you made them worse? It begs the question for all of the programs that look to do non-transport, including ET3, who loses in that scenario? Because if I purport to you that community paramedicine across the country has been propagated based on a mathematical error, what happens if you understand the readmission penalty to be a fine, but it's not? It's actually a reduction in revenue. So a hospital doesn't want to support your community paramedicine program because you're taking money out of their pocket. In fact, that happened in Goodyear, Arizona. So just a suburb of Phoenix that ran a community paramedicine program so effective that the hospital shut it down. That ET3, which is a combination of a whole bunch of things, anyone familiar with the concept of chimera? It's kind of like a serpent and a lion and an eagle all together, and it kind of doesn't fit together. Well, that's kind of how ET3 showed up. And so just yesterday, there was an article in EMS1 that talked about successful ET3 plans and how those are going to focus not only on the collection of information in the field, but on the connection of that information to a health information exchange. This is a very important issue in South Carolina, in North Carolina, across the country, as people start talking about aggregating data, connecting it with other parts of the ecosystem, and enabling others to see your information even on the way in. But the concept of a successful ET3 program is undefined. And what happens if you get that patient's information wrong? For example, y'all recognize this attractive fellow? Yeah? All right, so if you happen to go not too far from here, up to the Charlotte area, and let's say I was at a conference in Charlotte, I collapse, and I'm unconscious, and I'm wearing a name tag, and I think the statistic is like 90% of accidents and whatnot happen within 20 miles of people's homes, right? So I fall down, and someone shows up, EMS or Mecklenburg County over there, and they ask, who is this person? And someone says, Jonathan Fight. So they type my name into the EPCR system, and they run a search, and they find this fellow. Well, that's a problem. Not quite as attractive as the other guy. But wouldn't that be a problem if they do a match to a health information exchange or an electronic health record at the hospital system, Atrium Health, Carolinas Medical Center, etc., and they do a match correctly to the wrong person? But one could argue then, make sure you get the name right and so on and so forth, use a face or whatever it is. And wouldn't it be funny if you actually found me in the system a different way? Right? I'm looking here, I see Rob in front of me. Rob, you've got, your name could be spelled Rob, Robert, Bob, Ronsky, I'm sure a whole number of different ways that you've seen over the course of your life. Right? How do we know that we have the right person, and what's the implication of getting it wrong? Well, it turns out there's some research on this subject. And without going into all the details of it, the more we start to play with information in real time in the field and purport to share that information with others, we have to be careful. Because it turns out that patient identification errors, incorrect or ineffective patient matching can have ramifications well beyond a healthcare organization's four walls. How many of you are interested in community paramedicine? How many of you, I know there's a couple, how many of you are interested in ET3 and are being asked to share information more and more with hospital systems or other caregivers who have a stake in your patient's outcome? Well, everybody remember genetics class? I'm going to skip over this slide for a minute. Everybody remember genetics class? So what happens if it turns out that when you take care of that patient, you get a little bit of this guy, and you mix it up with a little bit of this guy, and then you mix it up with a little bit of this guy over the course of, say, 3 encounters. One was right, one was wrong in one way, one was wrong in another way. And what happens when that information gets dumped into the health information exchange? For example, in Arizona, North Carolina, Colorado, or any of the other states that are looking to connect the EPCR repository with the health information repository. Because as everybody in this room knows, EMS data is inherently dirty. Right? When's the last time you ran on a John Doe or a Jane Doe? Every day? Every couple days? Right? And at some point that information gets reconciled back into a health record, but when's the last time you got that information sent to you? But in the meantime, how many times have you seen that patient between when you started that record, dropped them off, and then got that reconciliation back? And if that information goes about, say, 3 steps from the point of origin, it's impossible to unwind without essentially a supercomputer. This information, as you start to talk about sharing this data with other people, becomes far more risky. And so I'm happy to share an article with any of you if you'd be interested. As you go forward and begin using using your data systems to share with other people, EMS Director Magazine, which some of you may have heard of, is one of the outlets that I write for, and they published an article with a list of questions. And those list of questions are those that I would recommend that anybody in the system talk to your various technology companies about, because it allows them and you to have a conversation about how your data are protected, how your data can be reverted if the patient's ID is found to be incorrect. Understanding the way that the data that you capture every day are used and shared and stored and accessed down the road will enable you to ensure that you minimize the liability. And so, just as a last point, because sorry for going a little long on this, I wanted to put the bug in your ear on the topic particularly of frequent users of EMS, of chronic care patients, of patients who are routinely unconscious or altered mental status, etc. There is much talk about common and universal patient ID, right? People hear about this topic all the time, about the ability to share information with the health information exchange and so on. Why is it that in 2020, when we can sign into our phones by looking at them, and we can sign into a Delta Sky Club with my finger, or a phone with my finger, or any number of other things, why is it that this industry hasn't yet started demanding the use of biometrics in matching patients? Wouldn't it be amazing if every time you showed up on a patient, whether they could talk to you or not, you could put their finger on a pad? If they don't have a finger, you could use a toe, an eye, or a face, and get a positive ID match almost every time, with the rare exception of a remarkable number of bee stings, or if basically that appendage is or all of them are no longer available. And so I hope that conceptually we can move the conversation forward, because all the information that you're capturing has value, but you have to be able to find it, and you have to be able to share it with reliability. Thank you guys all very much for allowing me to speak to you a little bit, and to the degree that I can answer any questions, I'll be here for the next couple of days. Thank you so much.
Thank you, John.